All right, let's finish out the week 6 topic by talking about antimicrobials. So here are some of the antimicrobials we'll talk about, basically antibacterials, antivirals, antifungals, antimalarials, antiprotozoals, antihelminth, and anti-TB or tubercular. So a few things to know before we get started on this. And look up the key terms in your books as well. But a pathogen is really an organism that causes disease to its host. Culture and sensitivity is really a test that is done to see if the antimicrobial drug that we want to use will work against the organism. A gram stain is a type of test that determines if the bacteria is gram positive or gram negative. A gram positive organism will take up the stain and it will turn purple, whereas a gram negative organism will be red or pink. This really helps providers to choose the appropriate antibiotic to treat the infection. A broad spectrum antibiotic will be able to target a wide variety of pathogens to include gram-positive and gram-negatives, whereas a narrow spectrum antibiotic targets very specific or select pathogens. These help to minimize collateral damage, so they're better to use them if we can. However, sometimes they may not work, or we may not know the pathogen that we're fighting. So we may need to use some of the broad spectrum antibiotics, at least until we know or are able to isolate the infection that we're fighting. Broad spectrum antibiotics come with a higher risk of superinfections or superbugs. These are a secondary infection that happen when we kill off the healthy bacteria in the body or the microbes in the body. These can cause secondary infections like C. diff, if you've heard of that. And then bacteriostatic versus bactericidal. Well, bacteriostatic causes the bacteria to stop reproducing, whereas bactericidal causes cell death. Of course, eventually this will all cause cell death, so I wouldn't get too hung up on this, but just knowing that there is a difference in bacteriostatic antibiotics versus bactericidal antibiotics. All right, antivirals. I won't spend too much time on antivirals, but there are many, including those for herpes, influenza, HIV, hepatitis, COVID. Acyclovir is an anti-herpes medication, but don't let the name fool you. It also treats genital herpes, chickenpox, shingles, Epstein-Barr virus, cytomegalovirus. EBV, or the Epstein-Barr virus, is mono. And there is some new studies that were released a couple of years ago that are making a pretty strong connection between multiple sclerosis and Epstein-Barr virus. So I'm keeping my eye on that one. Tamiflu is an anti-influenza drug, and this one must be given within 48 hours of symptoms in order to be effective. Some of the antiretroviral drugs are potent, and they can certainly cause renal impairment as well as pancreatitis. Patients generally have to take a very intense regimen and can still spread HIV while on these, but there have been several patients now to get to undetectable levels of AIDS, and undetectable means that you're not spreading it. Also, it's important to note that in 2022, the first mRNA HIV vaccines were given in phase 1 clinical trials with about 60 adults that were enrolled. And mRNA is also being used for possible cancer treatments. So lots of exciting things that are on the horizon for that. There's also 2 newer drugs that are antivirals being used for COVID as of mid-2021. And of these 2, it looks like Paxlovid is superior, although it does have several drug interactions, so its use needs to be carefully screened. But it's a combination drug, and it uses ritonavir, which is used to treat HIV, along with molnupiravir, was barely approved for emergency use because it has some safety concerns and it had some modest effectiveness. I guess if I had a choice right now and I needed one of these 2 drugs, Paxlovid would certainly be my choice, and that is the one that kind of has been used more and more as well. But keep in mind that there's also monoclonal antibody treatments like Regeneron or BAM that were being used for COVID. They're no longer being used because COVID mutations happened and those drugs stopped working basically, and the benefits didn't outweigh the risk. But there's also now pre-exposure drug, Shield, which is a treatment monoclonal antibody available. So these change all of the time. So lots of different, lots of new ones coming out. And I don't expect you to memorize any of those. I just want to give you a wide variety of education on all of this information, basically, for your program. So antifungals, well, fungus is super important to people. It decomposes stuff in the environment. It helps produce delicious cheeses. It helps produce many of our antibiotics like penicillin. However, fungi are opportunistic, meaning they can cause infection when there's a break in our defense mechanisms, like if we're immunocompromised. So while it's not usually a problem for healthy individuals, it certainly can be deadly for those who are not. But these are some of the fungal infections that are out there. Malaria treatments. Oh, I'm sorry, my picture covered this up. I'll be sure to change it in your guys' copy. But malaria treatments can be long lasting and may require 6 months or more of treatments. Patients often experience nausea, vomiting, and then they stop taking their medication as a result. So because of this, good education is actually key for these patients. And we should teach patients who are getting these to report these signs and symptoms so we can give suggestions like taking it with food or providing nausea medications to help increase compliance with these drugs. On a side note, the controversial COVID drug, hydroxychloroquine, was once used as an anti-malaria drug, but more effective drugs were then developed. Flagyl or metronidazole is an antiprotozoal, and you'll often hear Flagyl as being grouped together with antibiotics. It's a drug that has come for many uses, including Giardia, which is an intestinal protozoan parasite and causes severe diarrhea. It treats acne, rosacea, bacterial vaginosis, trichomonas, C. diff. And if we do this, we use the IV medication, but give it orally so that it goes straight to the area affected, as C. diff is in the gut, and that's where it causes problems in patients. Anti-helminth infections like roundworms and pinworms. I don't like talking about this. These are parasitic infections. Basically, we just treat them and do what you can to prevent any reinfection. So good hand washing, cleaning all bedding, washing fruits and vegetables. Not a fan of these worms at all, but those are ways you can prevent it. Anti-TB medications. We use what we call DOT, or direct observed therapy, for some infections that are very serious, highly infectious, and TB would be one of these. So drug therapy will need to take place for a long period of time, typically 6 months, up to 2 years, maybe longer. And we want to make sure that these patients, if you have TB, that you're not spreading it. So this direct observed therapy is basically when the patient comes into a healthcare facility and is observed taking the medication, so we know compliance has been obtained. Unfortunately, with some of these drugs that are listed on here, alcohol needs to be avoided because of the risk of toxicity. And also oral contraceptives can be much less effective if a patient is on these medications. So that's pretty important. Immunosuppressant drugs, monoclonal antibodies were also actually used long before COVID. We use these therapeutic drugs for cancers, inflammatory, autoimmune diseases, and to prevent solid organ transplant rejection. These T-cell blockers are common immunosuppressants that work by decreasing the activity of the immune system, which thus prevents it from attacking, say, that new kidney. Steroids reduce the production of antibodies, thus calming down our immune system. So we use steroids as well as an immune suppressant. And antifungals can be used because those who are immunosuppressed are susceptible to the fungal infections, like I mentioned, that can be deadly in those who are immunosuppressed. So this is why patients must wash all fruits and vegetables, and why we don't allow, often in hospitals, we don't allow these types of cancer units or these type of severely immunosuppressed patients to have fresh plants or live plants in their rooms either. All right. So that moves us on to our antibiotics, and here's some of the classes of antibiotics that we'll discuss. So first of all, we have some general adverse reactions that we see with antibacterial medications. We have allergies, which can be mild or severe, and I have some differences listed there. We have superinfections. I mentioned this before, that these are secondary infections that can occur in different areas, including like C. diff that develops in the intestines, but you can also have some in the mouth or lung or urinary tract as well as the skin. And then we have organ toxicity, which can occur to the liver or kidneys, or ototoxicity. So we monitor for all of these things depending on which antibiotic is used. Of note, I guess, when discussing these allergies, we can have some severe ones like anaphylactic shock that's listed there. The first symptom of this is often shortness of breath, and it usually happens within 20 minutes if it's going to happen. We treat that with drugs like epinephrine, bronchodilators, antihistamines. So anaphylactic shock is really the one that we get the most concerned about when thinking of allergies, as this is a very severe form of an allergy that fortunately is rare. All right, so penicillins being our first class, I have some examples of different types of penicillins listed above. You'll note that these all end in -cillin, so it makes these drugs easy to recommend. These are bactericidal. Some of the side effects are listed there, so watch out for those. Cephalosporins, then, these usually start with CEF or CEPH. There are many generations of these. I have 5 generations here listed here, and these have changed in coverage. So depending on what bug we're covering, depends on which antibiotic we will give from which of these generations. And I have some of the examples listed over here to the right. Do you want to watch out for kidney impairment with these, especially in someone who has a known kidney disease? And some of the side effects are listed up there as well. These cephalosporins, I consider to be a cousin to penicillins, so that if somebody has an allergy to a penicillin, it would make you question on if they should get a cephalosporin or not. Typically, for very mild allergies, we would still give a cephalosporin, but for those with a severe, say, anaphylactic type reaction to penicillin, we would not risk that happening again to the patient, and therefore would likely not use a cephalosporin, as these are kind of related to the penicillin group. We have our carbapenems. These usually end in penem. So you'll see the example there of imipenem. But these are bactericidal, and they're pretty broad spectrum, meaning they cover both gram-positive and gram-negatives, and a lot of them. We have monomobactums. Again, I have an example here. These are bactericidal. They have a pretty narrow spectrum covering just gram-negative bacteria. We have our sulfonamides, and I'm sorry, I'm not sure why some of my locations of names got kind of messed up in this, so I apologize for that. But these sulfonamides are like Bactrim or Septra, are some of the antibiotics you may have heard of. These start with sulfa. These are bacteriostatic, and these are gram-positive, and also they cover some gram-positive and also some gram-negative organisms. Next up, we have some of our fluoroquinolones. We do want to teach our patients and monitor for ourselves for this risk of tendinitis. So this is listed as a side effect here. This is where you can develop a ruptured Achilles tendon. So if you have a patient that's on one of these fluoroquinolones like Cipro or ciprofloxacin or Levaquin or levofloxacin, and they report that they have some pain in their lower leg, you would certainly want to screen for this. This would be something that the provider would likely then stop the antibiotic if this is an effect that they get. Pretty rare, but certainly can happen, and quite serious if it does. Our macrolides end in thromycin, so THROMYCIN. You see like azithromycin or erythromycin there. We have our aminoglycosides. These end in myosin although this can be spelled differently. So it can be MYCIN or MICIN, as in the examples that I have shown here. We also have our tetracyclines. These end in cycline. So CYCLINE, like tetracycline or doxycycline. I'll let you look over the information I have there. And that's it. So that is all for our antimicrobials. Please be sure to read the information out of your textbook to help supplement the lecture information as well. And you guys take care. Have a great day.